perspective is weakness or tearing of the posterior wall in the inguinal canal, because there's more space there. The canal is like 50% reduced in size and space in a woman. So that tells you right there that there's going to be increased pressure in the canal supporting those structures, and assuming you have good core intrinsic muscles supporting that area. So that's why women are affected less from an inguinal perspective. But a sports hernia, like we talked about, a lot of different terms. I mean, other things, automobile injuries, workers' comp, yard work, groin injuries can happen anywhere. So a greater understanding of functional anatomy, greater understanding of how it works, and then how to treat these is very important. Twisting, cutting, kicking, physical contact. There's probably some others, but those are certainly some of the bigger ones that why it's occurring. So I just came up with a little list here, going back to, again, you younger students that had anatomy. These are the big ones that you need to know how to palpate. It's certainly awkward, especially for the students. You can't get out and you don't want to be touching these things, obviously. But distal rectus abdominis, psoas, pubic symphysis, the adductor groove pectineus. I put fascial layers down there. Really what that means is every single one of these muscles, right, have fascia. But in the functional anatomy perspective, you have very large aponeuroses around most of these structures, especially the external oblique. That covers majority of the area overlying. So this could be injured and torn as well. Conjoint tendon. Anybody remember what conjoint tendon is? The common tendinous structure of the transverse abdominis and internal oblique. So when we have the inguinal canal, the borders of the inguinal canal are really the internal and external oblique, transverse abdominis. On the bottom, so on the bottom aspect of it is the inguinal ligament. And what's the inguinal ligament? That's just the extension of the external oblique aponeurosis, comes out as it folds over, and it creates this band of tissue that actually supports the bottom portion of the structure. You start ripping that, and you start getting bulges, and then therefore pain. Of course, the internal and external oblique, gracilis, all these attachments have some direct influence on pubic symphysis and pubic wall. So, yes, at times, it depends on the individual. It's hard to differentiate, palpating different structures, but you certainly can. And if you know the layers of what lies above and underneath these certain structures, you'll be able to perform your manual therapy from there. So the inguinal canal itself is about 4 centimeters. It's not too long, but think about a giant 4-centimeter straw, obliquely kind of back posterior from the inguinal ligament. And again, in males, again, like I said, it's a spermatic cord and nervous system nerves to mainly the testicles. In a woman, the raw ligaments in there as well. But if you look around, if you just look at where the pubic bone is and where all the muscular attachments are, then you'll be able to get a greater appreciation. Then there's something called a femoral hernia as well, and that's obviously dealing more with the nerve and artery going down. That's a little less common. Actually, that's the one that's more prevalent in women. I really couldn't find in the literature really necessarily why that's the case unless you have a bulge somewhere. Referring patterns of a hernia, even a sports hernia to some degree, but in a true hernia, if it's indirect or direct, a lot of the referral pain is obviously the testicles in males and the labia in females, along with the perineal area as well. So when you have that examination or telling you that type of pain, and when you look at the mechanism of injury, you can start kind of differentiating if is this a true inguinal hernia or if this is more of a sports hernia. So now we come to, again, what is a hernia? So the 2 studies I'm passing around for you guys to take pictures of and read are these 2, the British Hernia Society and an ADOA agreement within the last couple of years. Most of the other research that I saw was probably late 80s and 90s, using terms like sports hernia. But again, it's a non-descriptive term. So this is what we're going off of, really, these two studies. So again, within the last couple of years. So basically, these two groups have gotten together and tried to come up with more descriptive terms, or a term that the vast majority of experts can kind of narrow down to help, get a term that most people can know, understand, utilize, and create better outcomes in their patients that have pain in the groin. So, category 1. And I like this classification system because it's what? It's descriptive, right? If we call it adductor-related groin pain, that tells us the adductors are the problem, right? Or psoas, or inguinal, or pubic-related. So this is descriptive enough that we can say, okay, we can diagnose that lesion. We can still call it sports hernia, and that's fine. But we could say adductor-related sports hernia, or you can put whatever descriptor you want in there. But again, we have a term that's telling us the injury or pathology is in this particular area. The red, number 5, rectus abdominis external oblique. I put that one in there. That's, again, my opinion based on my experience, but also looking through the research. There's lots of studies that are talking about external oblique, and we see this in sports all the time when the docs are diagnosing it as an abdominal strain or something like that, or oblique strain. We hear it all the time in the twisting sports. You can classify that as a sports hernia, and so I just added that one into that area because it's more complete that way. Any questions so far? Kind of making somewhat sense. So I like that classification system. I mean, you can add stuff to that as well, as long as, again, the key is that you know your functional anatomy, you can examine well, you can palpate well, and what did we learn in school, especially when you're younger? 90% of your diagnosis is based off history alone. When you add your examination findings, and you can pinpoint down a little bit. Category 2 of that agreement is hip-related stuff. So yeah, you can have hip-related sports hernia, you can have inguinal, I mean, all that kind of stuff. But the big ones here is ruling out FAI. So everybody heard that term so far, right? It's becoming more and more common in the literature. We have one of our own Minnesota docs, who's one of the world leaders, Dr. Larson out of Fairview, does these surgeries all the time. A lot of us practicing chiropractors in the field refer to Dr. Larson when we see this type of stuff. And certainly labral tears. I mean, the orthopedic test for these types of lesions is sometimes based on solely your experience as well, and how well you can do that. But I wish we had time today to go through some of that stuff and the treatment stuff, but we don't. Maybe another time if we can do that. I do talk about this topic quite a bit in the PPE course that I teach for the college as well for the practicing docs, so when they do sports physicals and things like that, that they have this knowledge. Ruling out a true inguinal hernia. A lot of students in here are probably not at the level yet that you've had this in coursework. Just as a kind of funny side comment of checking for hernias, and you may have to do this if you're going to do sports physicals, or you're going to have to touch people's testicles, probably. But you may have to do the whole turn your head and cough check. So pay attention in class, because if you're doing sports stuff, you're probably going to have to do that at some point. But what is the purpose of turning your head during the cough? There you go. I was asked that once in the PPE class I was talking about, and I'm like, they thought it was something, with one testicle lower and other stuff. And no, you just don't want to be coughed at. So you got to kind of get up in there and see if you feel a bulge in there. So there's a lot of online tutorials on that as well. And if you don't know how to do it, or you need a refresher on that, probably highly suggest looking some of those up. And of course, through our imaging, ruling out degenerative joint disease and things like that. I mean, just remember, arthritis is not a age-specific problem, right? We see this in young athletes all the time, or young patients all the time. And they certainly can, once you have an x-ray, they can start doing the measurements of the femoral angle and or the acetabulum and start kind of thinking down the road if it is a FAI lesion or not, based on the x-ray findings that way. So don't be afraid to be imaging these hips, even in very young. Also, I do a lot of gymnastics work. FAI is rampant in gymnastics. It's normally why they have hip pain, but there's another reason why most gymnasts have trouble doing the splits. I know that sounds weird, but most of them can't because of the way their hips are formed. Rule out slip capital femoral epiphysis. So there's different disorders that way. Category 3, we can go through the whole list, but there's lots of other things to be considering. Even I've seen several groin cases that ended up being endometriosis. You know, even in a young female athlete. So just kind of look through all the different possibilities. If your exam and diagnosis isn't making sense, or you're finding, or it's time for referral. Then the other one is the British Hernia Society position statement. So they came up with the term inguinal disruption. And as I like the definition of it, it's still, when you hear that term, it is what? It's still not descriptive, right? It tells us you a little bit more common that it's part of the inguinal part, but it's still not descriptive. So it still could be lots of things. And remember, groin pain, you're probably potentially going to have multiple lesions. It's normally not an isolated, I ripped this, or this is torn, or this are frayed. In many cases, you're going to have multiple areas of dysfunction. A lot of the surgeries that are happening today, they'll have a labral tear, they'll have FAI, they'll have a true hernia. So most of the time, what are they doing? They signify that there is a sports hernia. They go into the posterior wall, they put mesh in there, so they open you up a little bit. They put mesh back there, kind of super glue everything back in to strengthen up that posterior wall. And then they're coming down, when there's an adductor problem, they'll actually release the adductor. They'll cut it, or at least part of it, to stop the abnormal forces that are pulling down on the pubic bone itself. So that's one of the theories on what's happening in most of the groin pain, is that you have tight and weakened adductors pulling this way, and then abnormal tension in the inguinal canal or around it coming the other direction. And you're getting these shearing forces on the pubic bone, and that's where a lot of the injuries and pain is actually coming from. But the definition, inguinal disruption, defined as pain of either insidious or acute onset, which occurs predominantly in the groin area near the pubic tubercle. Where's the pubic tubercle? That comment, I mean, there's a lot of stuff attaching into that. So it's just, you know, it's just lateral basically to the pubis symphysis. And that's where the chondroid tendon is attaching into, adductor longus. It's a very important part. So most of the diagnosis is when if there's pain, dysfunction, swelling, a bulge at the pubic tubercle, you should start being concerned that there is some type of groin pain or groin injury, because there is, again, a lot of attachment to that particular site. Where no obvious pathology such as a hernia exists to explain the symptoms. So what do we do in this case? I mean, I would start by checking, do they have a true inguinal hernia? Do they turn your head or cough? And, you know, basically you do the same to a female as well. You just get up in that external ring of the inguinal canal, cough, bear down, valsalva, something to increase the pressure, see if that you can actually feel a bulge or not. And then go from there. Then start your palpation of our list of, you know, anatomical structure. Is it painful? Muscle test them all. You know, that's one kind of standard there. Is a lot of these tissues that have disruption in there are going to be painful and resisted motion. Sports hernia generally, if it's a sports hernia, generally you're going to be pain-free at rest and symptomatic with exercise. A true inguinal hernia is both. And you're going to have pain all the time. You're going to have painful urination, you're going to have painful bearing down. Just laying there is going to hurt, so that's one of the differentiating factors with that. You need to consider that way. And certainly ask the genitourinary system on these patients if they're having trouble with urination, ejaculation, erections in males, those type of things, because again, that spermatic cord and nerves are going to be compressed if there's a true inguinal hernia in there. So again, I like the descripting part of that, but again, could be a little bit more descriptive. You could add to your descriptor on that if we're using that. But again, these are the two main current studies within the last few years on the consensus. Kind of like the concussion. The consensus panel meets every couple of years on that. Actually, it's October of this year. I forgot where it's at. Can you remember where the concussion is? It's somewhere in Europe they're going to be coming out with a new one, hopefully not a SCAT4, but they're going to be meeting to do that. This group is starting to do the same thing every couple of years. They're getting together, looking at the current research, what are some research studies that can be done, hopefully getting a body of knowledge to make this topic a little bit more clear-cut for individuals. So when we're talking inguinal disruption, so I guess put these 5 in your memory bank. So what do you do in school when you're trying to learn how to adjust? You go to your friends, your families, and they're guinea pigs, right? So now you get to go home and practice your hernia checks with your friends, maybe your family, but that's a little weird, but go practice checking hernias, practice palpating the close-knit structures of the groin. I was given this talk a couple years ago for the PVE, and it was funny because this woman, as I was talking about hernias and groin, she goes, well, women don't get groin pain. And I said, what do you mean? She goes, well, we're women, we don't have a groin. And I said, no, you don't have testicles, you do have a groin. Everybody's got a groin because you're adductors. Oh, so maybe I think she kind of skipped an anatomy class that month. So 1, pinpoint tenderness over the pubic tubercle. Again, lots of insertions are the biggest one, the cubic tendon, because again, transverse abdominis, internal oblique, are pretty important structures to stabilize lots of anatomical structures inside. Those are torn, you're going to be hurting pretty bad. 2, palpable tenderness over the deep inguinal ring. So you have that tube, right? That 4 centimeter inguinal canal right inside, internal ring. Deep ring or superficial ring is on the outside. That's where we get up in the groin and feel that hollow spot, turn your head and cough, feel for the bulge. 3, pain of the external ring with no obvious hernia. So again, obviously there's a bulge, you're probably going to refer that out to someone to do an ultrasound or something, or maybe an MRI or something to look at the inguinal canal, see if there is a bulge in that. If there is no hernia, you can kind of go around that sports hernia route or whatever we're calling it, or inguinal disruption or the other classification system. 4, pain at the origin and adductor longus. Again, that origin is also the pubic tubercle or whereabouts. It's a pretty broad attachment. Its adductors obviously are pretty strong pullers of the pelvis and pubic symphysis. 5, dull, diffuse pain in the groin, or referring pain to different areas is another one. Now that could be, that's an inguinal hernia. It could be also non-descriptive inguinal disruption or whatever we're going to call it as well. But what are you going to do? You're going to go back to doing your inguinal check, external ring, turn your head and cough, and those type of maneuvers to see if you feel a bulge. Now you can also feel bulges in a sports hernia as well, but it's not going to be in an inguinal canal. If you feel a bulge in an inguinal canal, or you're going up 4 centimeters and you feel a bulge where you think the internal hernia is, yeah, you have to go until proven otherwise, you have to assume that it's an inguinal hernia. Now, can you have an inguinal hernia and a sports hernia at the same time? Well, of course you can. You may have lots of things. I mean, there's football players that ripped adductors right off the pubic symphysis. That's a career ender there, typically. So you can have multiple things. There's lots of exam stuff, and I didn't put everything in here. And this is my take on it. Because what do traditionally, if you have a sports hernia and it's been diagnosed, what's done? Kind of the standard of care is that you go and do physical therapy or physical rehabilitation or whatever that you call that, and you try that for 1 to 2 months. And if pain subsides, there's probably not going to be surgery right away. Most of the work is being done in generalized core work and those type of things. I think since we're all a little bit higher level than just doing core work in here, is that we can expand it greatly. So, and students are a lot different now than even when we went through, that there's so many more options of fine-tuning your exam in terms of functional anatomy and functional assessments. So what I would do also as a part of your inguinal assessment, your palpation assessment, your orthopedic test, hip range of motion, those type of things to figure out, is there an FAI in here too, or are you suspecting a labral tear in here, is just run them through functional screens. There's lots of great stuff out there in terms of specific type work. I mean, we've got FMS, we've got the NSAM, corrective exercise model to go by, we've got functional foundation training. There's lots and lots of groups out there. They're all good. My take on all of that is it doesn't matter which one you use. What matters is that you master functional anatomy. So here in school, we certainly learn anatomy to a point. You're a lifelong learner when it comes to anatomy, but the functional stuff is where it's all at. So when you're examining people that, like I'm a big squat guy and one-legged squat, I can tell pretty much everything I need to know about those two things. And so what does the functional assessments actually do for something like this? It really tells us that we can pinpoint down what the underlying imbalance is. So on squat tests, if we see 4 different lesions of some type of external rotation or forward lean or pelvic going to one side, we can pinpoint exactly what is weak, what's too tight. Because that's important when we're talking about sports hernias, because you get any deviation from a squat, there's going to be pelvic and pubic bone symphysis deviation, right, or compensation somewhere. So using those type of tests may not go, you have a groin injury, sports hernia, inguinal disruption, again, whatever we're calling it at this particular spot, but it does fine tune it down to say, okay, now I'm in a general area, now I'm going to go to my palpation skills orthopedic test, all those type of things to, again, narrow it down. Once you have it narrowed down, that I don't think there's an inguinal hernia. I think this is more of a sports hernia thing. And we'll talk about treatment here in a second. We can go into that route. If it works and they're getting better, hallelujah. If they don't, in a reasonable period of time through your treatment, you can either refer right away and get your second opinion, or you can treat first and see if they improve. It also depends on the athlete, right? Not necessarily who they are, but what sport they are and what level. If they're a high-level athlete, I mean, they're probably most likely going to do surgery right away and then rehab after. But those consensus statements also talk about only about 60% are getting surgery. Conservative treatment is effective, and you're going to do the same exact thing after surgery. So regardless if they get surgery or not, you're still going to do all the exams like we just talked about. You're going to do all the same treatment probably post-surgery, depending on the lesion. But again, muscle test or do any type of resistance stuff, they're going to have pain on the affected tear, right? Okay. There's a large body of increasing evidence coming out, you know, again, like we talked about before, FAI and Sports Hernia. And a lot of times they are coexisting together. There's just tons of studies. If this is something that interests you, you know, just put FAI and Sports Hernia into, you know, any search engine or PubMed or something like that. You're going to see all sorts of stuff to read up on. But a couple studies I saw, one review suggested up to 94% of sports hernia cases had FAI in addition. That's pretty high. So as chiropractors and, you know, and some of you are probably ATCs as well, and EMTs and all that, depending on what you have. When we're dealing with hip pathology, chiropractic has a lot to offer, right? You know, if you have decreased range of motion and you're going into that hip flexion, adduction, internal rotation, and there's hip pain, you know, the lower level ones, chiropractic is going to help with that significantly because you're opening up that space and it's not pitching anymore. The bad ones, you know, may need some referral and or some work as well. But we have a lot to offer when it comes to even FAI. Some certainly. So what do they do in surgery? Anybody know? You got impingement of the hip. Basically doing a rotor, you're going in and shaving things down so you have more space. And again, I work a lot in gymnastics. A lot of young girls are getting FAI surgery so they can continue their career. And of course, they need a lot of work after, because that's not the true problem. If it was bony changes, that's part of it, but they have all the other compensation factors involved, so that's where we come in. When they coexist, and Larson, the sports medicine ortho here in the cities, his study from 2011 showed if there's an additional 40% improvement long-term and return to play, it's more significantly done when you do both surgeries at the same time. So a lot of the standard of care in the surgical world now is if you have FAI and a sports hernia that requires a surgery, if you do, I think the stats are, if you do FAI alone and nothing else, and you have a sports hernia, the success rate is like 25%. If you do just a sports hernia surgery, it's like 45%. When you do them combined, your success rate is 80 or 90%. So that's why, you see most of the time nowadays, they're releasing the adductor, they're strengthening up the posterior wall in the inguinal area canal, and they're fixing anything else that they see, or suturing up something. But there's normally, again at Hamlin, I would say this past year in Hamlin, I don't know what the number of sports hernias were, but they got to me for treatment. I probably had 15 cases at least that I worked with directly just this year in Hamlin. All of them that had surgery, all of them had adductor release, all of them had posterior wall strengthening up and mesh. The St. Paul Saints last year, we probably had half the team that had some type of groin pain and or previous surgery on a hip or a so-called sports hernia. And some of them, have not had surgery. Certainly not going to get surgery for that in that level of baseball in the given year. Okay, so we've got 10 minutes and we'll answer some questions. We may go to the room if there's more questions. But treatment versus surgery. So again, I said the standard of care roughly is treat away with different things between core strengthening, soft tissue work. I personally do a lot of, more of the active release type stuff, instrument assisted soft tissue mobilization to certain areas, chiropractic. I'm running through all the functional screens so I know what muscles I need to be working on. Taping, can kinesio tape, rock tape, you can use something like that to get in there and firm up the structures that way, give some support. SPRT tape, Tim Brown's proprioceptive taping technique, get in there, put a tab in there, and pull the structures where you need them to pull. And after that, after your manual therapy work, and see if they respond to that. Most of the time they do. I've never had a case that the athlete did not say, I feel much better. I've never had a case. Now, do some of them still go on to surgery? Yeah. Is it sometimes I'm the one that's sending them to surgery or recommending it, go see the team doc, I think we should do surgery? Happens all the time. These surgeries are pretty successful, relatively low invasive on the scale of going in. I mean, they're going in and putting mesh with some glue, outside infection and things like that, and make sure that they don't make a artery or nerve. It's a pretty safe surgery for the most part. Yeah, who's witnessed? Does school still do the whole going to Abbott, watching surgeries and all that kind of stuff? Do you still do that? Has everybody seen that yet? When you go into some of those surgeries, your jaw drops on how invasive those things can be. They're going in with basically a rotor rooter and a hand sand or a hand sander type thing and shaving off femoral heads and resurfacing and doing all that kind of stuff. But again, it's pretty effective in terms of that. They're not taking too much anatomy out, right? They're just kind of freeing some different areas up. So surgery is going to happen a lot. Like, as you look at the research again, 60, maybe 70% of people are getting surgery depending on their career. But asymptomatic, the research also shows asymptomatic sports hernias or even asymptomatic inguinal hernias, you can just leave alone. When you're doing sports physicals, the standard of care on that is, if it's asymptomatic, return them to play. You can, look online to some of the inguinal hernias. They look scary. There's a big bulge in that area. And if it's asymptomatic, are they doing surgery on an asymptomatic hernia? Almost never. And they just leave it. Is there a risk? Maybe a little bit more, but most of those are pretty stable. It's not painful. It's not putting, obviously, pressure to the arteries or spermatic cord or round ligaments or the nervous system or your circulatory system. It's not, for some reason. It's like a disc herniation, right? Not all disc herniations are symptomatic, right? We just leave them alone, right? Same type of thought. So let's use a scenario, you go and do surgery. Surgery gets done, probably fairly successful surgery. I had a Hamlin hockey player have surgery last Thursday for 4 lesions. Extensive amount of pain, ended her hockey season. We did therapy on her, we did all the stuff I'm talking about. It helped, but as soon as she got back on the ice, it came right back. So sent her to surgery. She had surgery last Thursday. She's on my schedule in about an hour and a half to start getting in there, and we're going to be doing fascial work to start with. As things are healing up, we're going to reinstitute all the rehab. She's working with the physical therapist at Hamlin as well. I'm coming in mainly doing the chiro, the instruments type stuff, the taping, those type of things. So it's going to be an interesting case today and see how she's functioning after surgery. Obviously, what the goal is that she's going to probably be skating by August, hopefully, getting ready for the next year. So you do surgery, and you're going to go in. What are you going to do? You're going to re-exam. You're going to do everything that you did before from an examination standpoint, figure out what's the same, what's better, and then you're going to go into the same thing. So educate your fellow medical counterparts in that you have lots to offer in terms of pre-surgery and post-surgery. Obviously, this is not well studied from rehab and therapy and tissue work before or after in the literature. But what makes sense is when your athlete is getting better and you can reduce the time that they are away from their sport, that's a win-win. at least they know that that worked, and you just have to be nice to, even for the college, it would be nice to track these things somehow, and that's not how my brain works. I'm not a researcher, I like treating them, but it's something that we could definitely have a lot to offer pre and post. So I certainly advertise for it. I don't see a lot of chiros advertising that treat sports hernias. I do. Well, next week, Kayla should be writing a nice sports hernia thing for our blog and all the other stuff. So it's due next Friday, by the way. So those two studies were part of the reference. There's some other hip and groin type things. Due to time, let's answer some questions. Again, I could have went on another 4 hours, but I'll save your day. So, questions about anything regarding hernias and things like that? Yes, sir.
Just a quick question. In your experience, when dealing with asymptomatic kind of return to play, do you find that the body tends to compensate for the actual pathology that's going on, causing further pathologies or structural pathologies later at orthopedic play?
I would believe yes, but that says future sports chiros and ATCs and all that stuff. That's part of your job, is to make sure everything is balanced from a triggering perspective. So yeah, their underlying imbalances will probably continue to happen potentially because of that underlying pathology, and that's that decision that you got to make at some point. You know, when would they do surgery? Or a lot of these athletes and or individuals, you know, if they're not an athlete and they leave it alone or elect to do surgery, but an athlete, they may do it in their career door. And we have a lot. I mean, I probably on the men's Hamlin hockey team, I would say 80% of them have torn labrums. Do we do surgery on a torn labrum? No, they're coming to me to try to balance it as best we can to keep them in hockey. And pretty much all of them will have labral surgery when they're hurt, type of thing. So, I mean, it's give or take, what's the best decision. If they can safely participate in their sport, and you may have to treat the other underlying problems and prolong surgery, it's not always my decision either. I mean, I'm working in a team situation where we have a surgeon, a medical doctor, PT, chiro, massage therapist in many cases where we're talking about those problems together, and ultimately it's the patient or athlete's decision. And in the world I live in, it's also the parents, of course, because it's their insurance. And in case you go to college years, the Saints are, for the most part, all older, so they wait basically till after the season. But it's a great question. You just have to do with the best that you can and keep treating. Alex?
Did you find any research or in your personal experience where if they did only, like, let's say they go on for surgery and have the hernia repaired, but they don't have the adductor released surgically, and then they were sent to you for just manual muscle work and soft tissue stuff, did you notice any increase in or decrease in the percentage that it works better?
Not directly. I've had plenty of athletes that had, I would say a couple, but the adductor problem and the adductor part of the groin pain or sports hernia is the easiest to fix from our perspective. My experience with the athletes coming and they're saying, this is fine now, either through time, surgery or not, I still have a problem here. And in a lot of cases, it's not being treated properly. You know, so then we get into that adductor and try to fix that tissue or change that tissue, and then the pain goes away. Am I answering your question a little bit?
Yeah, I mean.
So, I mean, the adductor stuff is going to be probably the easiest. The other stuff, it gets a little tricky depending on the lesion, but I mean, do what we do best. Treat what we find, right? If there's 100 lesions, you treat 100 lesions. If there's one, you treat one. And work on the combinations of those. And if you need help, send in someone with experience, or if you need a second opinion, do that type of thing. So, yeah. Any other questions? Yes, sir.
What information do you think that you share with like a head coach or strength conditioning coaches on preventative for hernias? You know, I mean, I know you talked about adductors.
Well, the main preventative stuff is really going back to your preseason PPE, your preseason strength analysis, and this is where we have a lot to offer as well. Is I don't care what you use. If you're going to go off and do an FMS test on all your athletes, great. If you're using another system, great. But if you can get to a person and look at what their true imbalances are and start working on those imbalances from a preventive and a performance perspective, yeah, you're gonna highly likely potentially prevent. Now, in the literature, it does show that in many of the experts, they believe that a sports hernia or something similar is going to happen when you have decreased hip range of motion. Who's the best at dealing with decreased range of motion of hips? We're sitting here. So if you can work on hips and get them, I mean, the gymnasts and the hockey players I work with in the institutions or the organizations, we're assessing them. We'll do the screens right away, and you're doing a hip program. We're adjusting, we're doing stretches, we're doing all sorts of stuff. We're trying to get to the underlying reason why you had decreased hip range of motion in the first place. So that's your preventive strategy right there. Is there any studies on that? I've never seen any. It's something that would be interesting, but probably also hard to study too. But you do what would make sense, right? And makes sense is to functionally assess them about what their imbalances are and go and fix that. And hopefully we're not talking about a sports hernia. So that's your value to the community or the teams that you work with. You do that well, you're going to get other calls. Any other questions?
I better shut it down there. Thanks for
Yeah.
around the hallway to answer more questions if you
I'll
need.
be around for a while.
If you haven't signed in yet, please sign in the back. If you have time to fill out the survey, please do that as well. Next month, third Thursday, Gate with Dr. Greg Untitled. Thanks for coming this morning.